Good morning, everybody. This is Dr. Ty Perkins. I'm Chief of Anesthesia here at Western Missouri Medical Center in Warrensburg, Missouri. We have KU students, CRNA students that come here about every 4 weeks, and we just had some new hires, so kind of want to make a video so I don't have to repeat myself every 4 weeks and say the same 45 to 60 minute spiel I try to go over. We're just going to kind of do a nice general OB overview, starting from when you put the epidural in, from epidurals, laboring, C-section, technique, solutions, bolusing, and reevaluating the epidural. So we'll kind of go over top to bottom overview of that. And if you have any questions, you can always put them in the comments below, and if I see anything I can respond to, I will. So we'll start out today with indications, and I've had some people rotate through. We've had locums docs, CRNAs rotate through just because we were short staffed like everyone through coronavirus, and I'm always amazed that anyone even argues with a midwife or a OB doctor if they should put the epidural in. But really, I don't think that's part of our responsibility. That's not what's on our name badges. That's not our specialty. So really the indication's active labor, and if they say they're in active labor, then just go put it in and don't argue, because it's not really going to solve anything. It makes it awkward for everybody. We'll move on to the technique here. So we do about 800 deliveries a year. There's me and 6 full-time CRNAs here. They all take call and have independent practice, so they all do exactly what I do, minus I run the department. So they all got to be really skilled, and they gotta have good hands, make good decisions, all that. So we got a good group here, but it really when you're in a facility like this and you're kind of out in the middle of nowhere, there is no other specialist, so you will be what everyone turns to. So if you don't have good decision making, good skills, it's hard to take a job like this. So we'll talk about our technique here first. So I think where a lot of people mess up on the technique part is there's 2 different things. One's the angle of your needle going in, and most important is being midline. So I think a lot of people mess up midline when you get up to bigger people and your BMIs get up above 40 or so. You might not be able to feel the spinous process. But if you're not midline, you pretty much have no chance of getting an epidural in a traditional technique where you're backing out and going up or down to try and find your spot. So you're probably not gonna appreciate my artwork very good. I'm not a very good artist or anything like that, but I'll try to kind of show you what I'm talking about. So so we're talking about midline. We're gonna put like some spinous process here. This is I don't know, it's not a very good drawing probably, but. And then say this is the hole we're trying to go to get to our epidural space, and then around here is going to be bone, right? So it's not like in between each spinous process, no matter where you're at, you're going to hit it, right? So this, if you're getting past the spinous process, you can actually feel. If you're not midline, you could probably see it'd be really hard to put one in, say if you're on right here, which is not that far off, but even if you hit right here, the depth will be pretty deep. You're still looking at, on an average person, 6 to 7 centimeters, as opposed to 2 centimeters on the spinous process. But if you're just doing this, and then you back out and try and go up, or back up and go down, you could probably understand you'll probably never get the thing. And if you numb adequately, which numbing straight in with your lidocaine, they're not going to be able to tell you left or right, which most of the time you can't really depend on that too much anyways. So really focus on feeling the spinous process. So say you feel the spinous process here, and then you feel one here. I don't even feel the one below, but if you feel one here, you go down about 1 centimeter and try and stay exactly in the middle of that spinous process, and then that's where your numbing is. I try to get a good white subcutaneous injection. I want to see a good white circle there, and then I'll come from the side on that, and then we'll go straight in, and I'll go as deep as that needle can go, and I'll push all 3 cc's or whatever is in your numbing kit. Usually it's a 3 cc syringe, and be generous. Go in and push it in on the way in, and then once you get in all the way, plow the rest of it and be done with it, and move on with your life. So that's kind of the view like this. Sometimes on people that have like a BMI of 40 or so, they're really big and you can't feel any spinous process. You might, after you do quite a few and are very comfortable with it, you might be able to kind of feel an indentation where there might not be a spinous process and there's kind of a hole there. You got to get really comfortable and very experienced to get that usually, so it takes a while. But say you can't feel it hardly at all, a lot of times there's these paraspinal muscles on each side. Sometimes you can kind of feel them, and make sure your thumb's in between if you feel like a paraspinal muscle here, and you can kind of work your finger in the middle of that. Sometimes they're so big that you can't feel anything, and in that case you have to use the butt crack or the gluteal cleft, and that's kind of where you have to start at. Of course, we all feel out here for L4 on the iliac crest, so really if you got L2 to L4, you got a few spots up from that you can go. You might be able to go down one if you want. One of the other ones with the really big BMIs, and they got a lot of redundant tissue back there. You might have the butt shelf, where the whole shelf of the butt kind of starts going out. If you can go above that, the loss of resistance the distance to the loss of resistance is a lot less than if you're going into the shelf, if that makes sense. If you do enough epidurals, you'll know what the butt shelf is if you run into that. The other thing I think where people mess up a ton is, I'm going to erase this, and I'm going to talk about the needle angle. Hopefully I don't knock this thing down. So, okay, say this is your back. We're looking at it from the side, and somewhat, you get a patient that can actually somewhat do that, which is not a lot of them, but let's just be theoretical, okay? Say this is, I'll just say this is L2 or L1, and down here is, we'll say this is L5, S1, somewhere around there, S1, something. So you kind of got that. So you got a little bit of a kyphosis there. So it's not completely straight. If you can get that, that's really good. Most of the time you can't because they have a baby right here, and it's really hard to do. They're in pain, kind of sucks. But the one thing I do feel like every time I see, I'm just going to make spinous process coming out here. Okay. And like I said, don't judge me here. I'm trying to make it at a different angle. It's probably not going to work, but is your needle angle. If you ever watch people, everyone does an epidural. I'm going to say this is the hole we're going to. This is more lamina and os. You're hitting bone. That's the hole we're going to. Remember, I said you have to be midline to even get to this hole. You almost have no shot if you're off midline. But then when you go see people, they're always doing this, coming in like that, which works in thoracic epidurals because the transverse spinous process are pointing down, but in the lumbar they're all sticking out, so pretty much straight out. So, and I was taught this a long time ago, but you always want to do in labor epidural, you want the needle to be completely perpendicular. So remember the perpendicular line we could do at any angle. This is probably going back to some type of geometry thing we had. So if I was putting it in here, that would be my angle. There'd be a 90 degree right there. So instead of trying to get to this hole right here, watch my angle. Worst thing you could do is this, right? And then you bring it down and maybe you'll clip the top of it right there. But the easiest way is to keep it nice and straight, right? So if you go here and you hit something that's not this, right? Not the, 2 centimeter or so spinous process. But if you hit something here and you are midline, all you gotta do is go up or down and keep your angle of your needle straight. Now, if I hit something right here, will I back out and put my angle just like a little bit like that? Sure. Well, sometimes I come up like that. Sure. But if I don't like where I'm at and I think I'm hitting down here, and I'm pretty sure I'm midline, I'll bring the needle back to the skin, keep the same poke hole, and either raise or lower the poke hole. So almost out of the skin, pull it up and then or pull it down, just because you're not that far off if you know your midline. So, all right, we'll move on from that. Okay, I did talk about being generous with the local. I think another good thing, and I'll have notes on all this stuff that I'll attach to this video, but I think another good thing that not a lot of people do is when they put their local in, you get a 5 cc 1% lidocaine in most kids plain, and then you get a 5 cc 1.5% with epinephrine in the kit, which is for the test dose. Really, you only need 3 for the test dose. You can put 5 in for the test dose, but I don't know how many years ago somebody mentioned it to me, so I just started taking 2 cc's of the 1.5% lidocaine with epinephrine, and then 1 cc of the 1% plain lido, and that's what I use for numbing. That way in the skin, where you're at, you have some epinephrine in the skin that can vasoconstrict, because you got to realize we're putting a needle in and the catheter is smaller than the needle. And so it's always going to have more of a likelihood to bleed or ooze whenever the catheter is smaller than the needle, and you take the needle out and the catheter is in a hole that was slightly bigger. So I think ours, the catheter is 19 gauge and the needle's 17 gauge. So if you can add a little epinephrine there, it might not bleed as much, especially if you're trying to go fast and you don't want to sit there and hold at the end, which we've all done because it's bleeding, the spot's bleeding right where you numbed and where the needle is. You got the catheter in, you're just waiting to lay down for that. Okay, what's next on our notes here? So if you ever look, the books will tell you to place the catheter 3 to 5 centimeters past loss of resistance. So for whatever reason, even going through training, people have me overstuff them all the time. I see people overstuff them all the time where I'm at. I've never understood overstuffing epidural when the book says 3 to 5 centimeters. I used to go 5 centimeters when I first got out 9 years ago. But I went back to 4 centimeters just because I wanted to eliminate the possibility of me needing to come back, pull the epidural out a centimeter, re-bolus it, and see if that worked. So, like just last night, we had a real skinny girl, and I had a loss of resistance literally at 4 centimeters, which is about, 3 to 4 is about the lowest you're ever going to see on any adult anyways. And I taped it at 8 centimeters. So it feels weird when you first start doing it because, the solid line's at 12. You feel like you should always have it at 12 at least, but the major, there's usually 2 risk factors of having unilateral epidurals. One is overstuffing, because it's more likely the catheter will jump out of a nerve root the more you overstuff it, which is why the recommendation is 3 to 5 centimeters to put in. I haven't been bold enough to go back to 3 centimeters just because I know they move around and they get sweaty and whatnot, but they don't have the epidurals in that long compared to some, if you talked about operating room epidurals, sometimes they can, for whatever big surgeries they're having, they can keep them in 2 to 3 days. And so if I ever put those in, I put them at 5 centimeters, but if it's an OB one, I put it at 4 centimeters because stuff can happen fast. The last thing I want to do is pull it back, bolus, nothing changes, pull it back out, put another one in, bolus that one, and then you're just bolusing on top of bolusing. And so then you have a ton of local back there. Just, it's not that good for when someone's trying to have vaginal delivery and you're increasing your tachyphylaxis. So 4 centimeters is good. Don't feel weird if you have to tape it at 8-9 centimeters. So it will feel weird, but you hardly ever see anyone do it. I don't know why. So and then the other factor for having unilateral epidural is usually multiple epidurals in the past. Like anything, there can be a little scar tissue. When you put it in, pull it out, there might be a little nidus of inflammation, and you see someone who's on their 4th or 5th epidural, and you pick a same spot that 2 or 3 other people did, and you place it, and you put it at 4 centimeters past loss of resistance, and you get a unilateral epidural. So in those instances, I just come right back. We do an ice test with them. It's unilateral. Their pain's not that well controlled. They're telling you this leg's way heavier than the other. The ice test, which we'll talk about later, just pull it out because you're already at 4 centimeters and go up or down one, and usually that works. So the solution, we've had a few solutions here over my time. Right now we're at 0.2% bupivacaine. You can use ropiv too, with 2 mics of fentanyl per mil, which the fentanyl seems pretty standard. You will see 0.125 bupiv or ropiv with the 2 mics of fentanyl too. So I haven't noticed any difference with either of them. We adjust them a few mils for the bolus and for the demand dose. So like right now we're at 0.2 bupiv with 2 mics of fentanyl, and we run them at 10 an hour and 4 demand every Q15. And really, we don't do in-house calls, so we live in a small town. We all live within 10 minutes of the hospital. So we do it from home. So really, we're trying to make sure the patients are really taken care of, their pain's well controlled, but we want to minimize how much we get called because we're not 24-hour in-house OB. We're not 30 seconds away, sleeping in a room right next to them. So I think we got that pretty well taken care of. They don't call us too much for boluses unless it's truly indicated. So. Okay, initial bolus after an epidural. So you place an epidural, and I don't really bolus it until they lay down. The test dose is when you're sitting up, but the test dose is saying, hey, am I in spinal space, am I in the epidural space, am I in a vein or a nerve? Obviously, if the test dose has epinephrine in it, so if you're in this an artery or a vein, your heart rate's going to be like 150 in like 30 seconds. You're going to see their carotid pumping out, the blood pressure's going to be through the roof, so that one's not usually hard to see. The aspiration doesn't mean too much because that catheter is so long and skinny. You could aspirate, especially if you're in a vein, the vein could collapse. Even if you're in the spinal space, you could aspirate, nothing could come back. I mean, I've aspirated where some stuff comes back, but it might be some of the local I put in, or not local, but some of the saline I put in when placing it. So I don't know. I just the aspiration I don't take too much from, unless you're just like pouring out stuff that feels like CSF. So if you've ever felt CSF on a sterile glove, it's like 10W30 motor oil feeling. Saline has a little resistance to it when you're kind of moving your hands, but the proteins inside of CSF is really slick, so you'll be able to tell that pretty decently. So the initial bolus, you really shouldn't give until they're laid down. The test dose kind of is what it is, but you're not really using it for pain management. So if you lay them down and wait for gravity to take a hold, if they're laying as flat as they can, all the way on their back as they can, that's when you want to give the test dose because everything with an epidural works with gravity, so you want it to go to all spots, go as high as it can, low as it can, left and right equal. When I do have them move back from the bed after the test dose, I've taped them up and then I move them back to the bed. I do want them to move their legs up onto the bed. Now if they're hurting so bad they can't do that, I'll let a nurse assist them. But otherwise, I want to see them move their legs to the bed, because then it's not spinal, because by that time you've given the test dose, you're about 2, 3, 4 minutes since the test dose. So if you had a spinal, it's not even a question. They won't be able to move their legs. the 2 times I've had a catheter where I didn't have any aspiration, I didn't think anything, but it must have went in the epidural space and punctured through the meninges somewhere, and was a spinal catheter. Both times they definitely could not move their legs back to there, and they were thanking me how much pain control they got. So the flags are going up when they said that, because all I gave them was 3 cc's of the test dose while they're supine. And sure enough, when they went to go move the legs over, I couldn't move the legs. So it's definitely a spinal catheter. So it's good then I don't have to, you don't even have the option to bolus that because you already know it's in the spinal space. So. Okay, so then you lay them down. Generally I try and give like 5 cc's of the 0.2% bupiv ropiv with fentanyl as a bolus once I lay them down. Everything's dependent. I mean, it's hard to go through every scenario here, but if somebody's in early labor, 2-3 centimeters, they just started in active labor. If I lay them down and give them 5 cc's of that mixture, usually, within 10-15 minutes, which is the peak effect of an epidural bolus, you'll get an idea if that's going to be a good epidural or not. So generally I'll lay them down and I'll push it in. I don't really put it on the pump ever, just because if you're on the pump, I feel like it takes too long to get that medicine in. I'd rather just slam it, see where it goes, and then I go off to chart and then come back in 10 minutes or so and just make sure their pain's better. Now if they're more advanced along in labor, if they're going ballistic when I'm putting it in, and I know their blood pressure's okay, I might give them the rest of the 1% that's in there as well. So if you do it kind of the way I said, you'll have 4 mils of 1% plain Lido left. So even if I go chart and they're 2 centimeters and I give them the 5 mil bolus, I'll shove the extra 4 mils of Lido in my pocket as I go out there to make sure they're feeling okay. And especially as you get on to multiple kids, you go a little faster, you'll kind of get the hang of when you can give that, who you can give that to, make sure you eyeball the blood pressure, because you are going to have a little bigger sympathectomy for that. So let's see, what else do I want to talk about there? Good. And then the other thing I kind of want to say about that is you really want to try to minimize what local you give up front. So, if you go in, and this is what happened in the 80s, we go in, not that I was doing them in the 80s, but, when epidurals first started coming out, we'd go in there and plow them with all this medicine, and you'd be their best friend because they had no pain, and, they had 0 pain, but then you weaken their abdominal muscles, everybody got a C-section, epidural's got a horrible reputation, people would be repeating spinals, so really the point isn't to give them no pain, it's to minimize their pain and make it, the sharp pain go away, and ideally take away 70-80% of the pain. I think giving them unrealistic expectations, especially up front when they're in early labor, and saying, hey, here's some 2% lidocaine. I've never given someone 2% lidocaine up front. The only time I give you 2% lidocaine if we're going to the OR for a C-section, and we'll talk about that later, but that solution's really for surgical anesthesia, not labor pain. So, but the more medicine you give and the higher concentration you give, the more tachyphylaxis you give, and the less likely your epidural's gonna last long. So usually epidurals in that scenario, in a labor scenario where you're given a lot of medicine, that's a little more dilute, than some of the medicine you can give. Usually 12 to 18 hours is about all you get out of one labor epidural, and you're gonna get tachyphylaxis after that. The more medicine you put in there and the higher concentration you put in there, the faster that's going to happen. Okay, so that looks good. Good. Okay, now here comes to the part where a lot of people mess up, which is evaluation of an adequate epidural. So this includes coming back and checking on them after 10 minutes. This includes, hey, we're calling you back. you know, mom's in a ton of pain, or, you know, she has a hot spot, this and that. This is probably where I see most people mess up the most, because you just start plowing an epidural with bigger and more stuff. And there's certain scenarios you want to bolus them, but I always like to talk about if it's a bolusable epidural. Because if it's not, if you taped it at 4 centimeters, just take it out and put a new one in, right? You know, otherwise you're going to waste an hour and a half of your life, and if they're 8-9 centimeters, you might not even get a chance to put another one in and make them comfortable. So, so pain is the best thing. You know, I don't go in there trying to check level and all this after I put it in. So if I go back in there and they say their pain is way better, they feel good, thank you, their blood pressure looks good, I don't really need to check a level or do anything like that. You know, pain is the best indicator. One of the caveats I did put on here is sometimes they'll have you put an epidural in for like a multip that's you know, that has went fast before, and you're going to put an epidural in prior to them breaking their water or something like that, which, you know, that's fine, whatever. You know, it doesn't bother me one bit, but you might have someone that has zero pain when you put it in. So coming back in and just saying, hey, you all right? You feeling good? Yeah, all right, see you later. Your blood pressure's good? Yeah, see you later. That's not really going to work on them. So then it comes back to the second most important thing. So pain is your best indicator. And the second best one that I always use is temperature. And I don't use alcohol swabs or anything like that. I don't know, those seem really unreliable. I like ice. So go to the ice machine and get a little stack of ice and put it in a paper towel, 2 paper towels together, tighten it up real tight so it kind of all congeals to itself. And you know if they have temperature control that the medicine's getting to that side. So say someone's broke their water, or they haven't broke their water and you have to go put an epidural in. Or you come back and they're like, oh, this side doesn't feel very good, but this one does. My pain's okay, but I do kind of feel it over here. Or you're coming back to re-evaluate an epidural, you know, 6 hours later, and their pain is, you know, went to a 6 or 7 or whatever. I'm always grabbing that ice, and I'm going to put it right on their knees, on their kneecaps, right on the medial portion of their knees. So that's going to be an L3, L4 dermatome. And if you put it there and then put it up high up on their chest and you ask them, hey, this should be way cold, this should be either nothing or almost not cold at all. As long as you got bilateral there, you know the medicine's going to both sides, you can finish your evaluation if that epidural is bolusable. Because if the medicine's actually getting to both sides, you can go ahead and bolus it. Now, if you go here and they're like, oh yeah, that's pretty cold, really cold, and that's really cold, and I can't really feel that, but that's really cold, pull it. Because normally that'd be the point where you pull it back a centimeter, but in this scenario, like I said, we're going to have it at 4 centimeters anyways. What are you going to do, pull it back to 3 centimeters? I don't know, that seems weird. Maybe some people do it out there, but I wouldn't. I would just pull it and go to a different level. So the ice is always the most important to evaluate when it comes to that. What we were talking about before there. So basically with the ice concept there, I decide if it's an actual bolusable epidural. Now that also goes to if I'm going to the OR, I'm reevaluating for pain, or my initial evaluation if they didn't have pain to start with in the scenario where they're breaking someone's water. I'll always just go get ice, just make sure, because if I'm moving on with my life, I want to make sure they're not going to call me back in 10 minutes and they break their water and they're like, hey, yeah, the left side's okay, but the right side feels horrible. Okay. And I'll also use that, so if they do have like a hot spot somewhere on their belly, as long as I know the medicine's getting to both sides, I'll still consider that bolusable too. And we'll talk about Precedex here in a little bit, how that kind of changed the game on what we do for OB and what we put in the epidural space. Because back in the day, you know, before, I don't know, a year or 2 years ago, before we had Precedex, you know, you just have to try to bolus them with other stuff and hope it covered the hot spot. Because usually, probably, if you were getting bilateral coverage with, you know, the medicine's going bilateral, unless the hot spot is huge, you know, you probably wouldn't pull an epidural just for that. You know, and like I said, if you tape it 4 centimeters, you're probably not going to do that either. So, say I come back and they're like, oh yeah, I mean, there's a ton of pain. So I still got my 4 cc's of local in my pocket. If I didn't give it to them up front, you know, if they were 7 centimeters and going ballistic when I'm putting the epidural in, I'm probably just going to give them the 4 cc's of 1% on top of the 5 mils of the bolus off the bag. Probably before I leave the room, especially if I see their blood pressure. You know, if someone's in horrible pain, you know, usually they're going to have the pressure to be able to handle, you know, mild to moderate sympathectomy from that. So I'll give them that. But say it was a 2 centimeter and, you know, she's kind of wincing, but it's her first kid. And you go in there and you put the epidural, put 5 mils in there, and her pressure was 128/76. I'll go chart, come back, and you know, if they still have some pain, and if it's significant, like moderate to significant pain, I'll go get the ice, and I'll do the ice, and they're like, and if they say, yeah, I don't feel it much here, don't feel it much here, but holy cow, it's cold up here, I'm gonna give them the rest of the solution that's in there. And if they told me they were 2 centimeters, you guys have all probably been this, oh yeah, they're 2 centimeters. Well, that was 4 hours ago. And you know, I put an epidural in, I gave them the 5 mils off the bag, and they're still at a 7 out of 10, and they're wincing. They don't look like they're that much more comfortable. You can tell the medicine's going to both sides. So I'll give them the rest of the lidocaine, and then I'll step out and have them recheck them, just to make sure what I think's going on is going on. Because if they're still 2 centimeters and they're having that much pain, now, you know, I'm thinking, is this epidural that good? But if I confirm with ice that I know medicine's going to both sides, I feel a lot better about it. And you know, everybody feels pain differently, so you can't really tell people how to feel pain. And you know, if you do anesthesia, OB anesthesia enough, you'll see the dramatic side of some people having a baby, and then you'll see other people just handle it so cool and chill and relaxed. So it's hard to tell someone they're not having pain when they are having pain. So bolusing, coming back, still do the ice thing. That's how you evaluate if it is bolusable. I don't know if that's a word, but we're gonna make it a word today. I never bolus more than 0.25 bupiv, or you can switch ropiv in there too, or 1% lidocaine. So both of them are about equivalent on potency. And if you get up to like 0.5% bupiv, 0.5% ropiv, or 2% lidocaine on the labor side of trying to bolus, really the percentage is so high that you're going to start giving them an abdominal wall weakness. Well, they're trying to push something out of their vagina. The worst thing you can do is make their muscles they're trying to push with even more weak, because even just a regular epidural, you might make some of those muscles a little weak. So that's why we don't just go plow people with spinals. Well, spinal narcotics is one thing, that's not going to do much, but spinal local anesthetics on people that are having labor pain, right? So like I said, we don't do in-house anesthesia, we do it from home. So we don't do CSEs here generally. If we do, it'd just be narcotic. We dump in the spinal space, unless someone wants to stick around. But I don't want anyone to dump some medicine into the spinal space that's a local anesthetic, and then put an epidural in as local anesthetic, and then just drive home. So most of the time you don't need to. And if you work at a place similar to this, you'll understand you can control pretty much almost anyone's pain with an epidural. At least make it a ton more tolerable. So there'll be maybe 2 or 3 times a year I'll do a CSE, and it'll be someone that's like complete 9 centimeters, absolutely going ballistic, but they're not feeling like they have to push, and I might have a little time to have someone open the little additional CSE kit, and you know, I'll throw like a mil of 0.25% in there. And even then, you're so close to delivery that if you weaken those abdominal muscles a little bit, it's not a big deal. But you know, if you start weakening people's abdominal muscles that are 4, 5, 6 centimeters and they're not too complete yet, you know, they haven't actually gotten to that point, that's where you're really going to increase the C-section rate, especially up front. Someone's 2 or 3 centimeters and you're just plowing them with 2% lidocaine because your shift's over in an hour or 2 hours, it's 5 in the morning, you don't want to get called, and then you know, just move on through life. So. But it usually screws the person coming in behind you. So that's kind of what I wanted to talk about, bolus. So that's for labor epidural. And remember, the more you bolus, the more you create tachyphylaxis, and the less likelihood the epidural is going to last as long as it could. So if you take an epidural that's not very good and it's really not even bolusable, and you just keep bolusing and bolusing and bolusing it, and you get somewhat okay results, A, they're going to keep calling you back, but B, you're going to increase tachyphylaxis everywhere for that. So really you just want to pull it out and put a new one in. Bolusing for C-section, like I said before, that's about the only time I'd use 2%. I don't think I've ever bolused with 0.5% bupivacaine. C-sections they're coming from epidurals are usually like, hey, let's do this, we need to go. So I'm not going to wait for 0.5% bupiv to kick in. So I don't know what scenario I'd use 0.5%. I can't really think of one that I would bolus an epidural with 0.5%. So, but if it would, it'd be for surgical anesthesia, because you're definitely going to be more likelihood to weaken their abdominal muscles. So I would definitely not put it in labor. Bolusing C-section epidural. So this is kind of traditionally try to give 2% lidocaine with epinephrine. It doesn't have to have epinephrine, but 2% lidocaine. Try and get about 20 mils in there. Usually I try and get 10 mils as we're going back to the room. We'll talk about Precedex in a little bit of how that kind of changed what we did, but you try and get 10 in, get a blood pressure or so in, maybe put another 5, just make sure the blood pressure is tolerating it. Usually by that time, if they've had a ton in their epidural space, they already have some tachyphylaxis, so you're not going to get a raging sympathectomy as you would if you put 2% up front. So you just went and put an epidural in and put 10 to 20 cc's of 2% in an epidural space, you get a pretty good sympathectomy. But after, usually these have been in for hours, and you really won't see a huge sympathectomy, but you do need to keep an eye on it. So usually, like I said, just try and put 10 in, and then 5 and 5 if you can, as long as the blood pressure is going okay, and realize that they're going to cut in 8 to 10 minutes. So you want to get that in there as fast as you can. So as soon as you see the patient. The other thing with taking an epidural to the C-section room is so important to make sure you're not riding a dirty epidural. So that's probably the other problem I see with people is over-bolusing and then taking a non-working epidural, and taking it to the OR because you're not sure of your skills, you're too lazy, I don't know what it is. Some people just don't want to do procedures ever. So they'll take that epidural to the OR, and then that's when not good stuff happens, okay? So if you go in there and they say, oh, their pain's good, they're fine, you got to really keep an eye on that. Okay, when was the Pitocin turned off? Because they might have turned the Pitocin off 60 minutes ago and then called the OB doc in 60 minutes, said, hey, these are the fetal heart tones. This is what the tracing looks like, whatever, that's not my specialty, and they're like, oh, okay, let's go do a C-section. Well, then they call you, oh, this epidural's coming in, or is already in, we're gonna do a C-section. You go over there and you talk to the patient, hey, is your pain all right? Oh yeah, I'm feeling fine. When really the Pitocin's been off for an hour or two, but when the Pitocin was gone, they had some significant pain, but you really don't ask about that because you just assume that their uterus is still contracting. So those are the ones where people get real off on, they get real off to the side on, and they get in a tangent, and then you run yourself into a hole. Once you're draped up and you got an epidural there's not much you can do if it doesn't really work that well. So ice test is important then. If you get ice here, like we talked about before, take it, if it's a bolusable epidural, take it to the OR, try and get the lidocaine in as soon as possible. I'm going to talk about Precedex next, so that's where we would change that scenario a little bit. But if that epidural, if it's a dirty epidural, take it out and put a spinal in. As long as you have time, it's not a stat C-section. Take it out and do a lower dose spinal. So usually I give most people about 1.4, the hyperbaric bupivacaine. But if you're coming back to do an epidural, epidural going into a C-section, and you didn't think it was good, you pulled it, I would cut it back to 0.8 or 1 of that. If you have if you have time, you can still put some morphine in there, 200, 250 mics, somewhere around there. But a lot of times that's like urgent. You don't have a lot of time to pull a whole lot of stuff up. So really just pull a mil out of the kit, because in the epidural space there's going to be a ton of fluid in there anyways. And you know, so you're going to have some epidural. Even if it's bad epidural, it means it's just not a surgical epidural, but you're still going to have some epidural liquid that's helping some pain somewhere. But especially if you have to use a bigger needle because you're going quick, and you know, you pull a 22 gauge out and do it because there was a little bit of fetal distress that's resolved, which we'll talk about here in a little bit. You know, if you have a good sized hole there and a ton of fluid in the epidural space, you know, if you make a 22 gauge hole in the meninges there, you know, you can have some of that medicine cross over in the spinal space. But so that's just my experience. You know, I don't, you know, you kind of decide what you do when you get out, but like 0.8 to 1 is about what I do if I have to pull an epidural that's going to a C-section that's been going a while. So pretty much any epidural because you've already bolused it. So. All right, let's talk about Precedex. So Precedex kind of changed stuff. You know, it's been out a while, but really for OB anesthesia, I haven't noticed people using it for, we've been using it for maybe a year, 2 years, somewhere around there. Of course, it all went generic a few years ago, so that made it way more widely available, and way more hospitals were able to put it on their formulary for a reasonable price. I think we pay $13 or $15 a vial, so definitely better than what it was. So remember, when you're giving Precedex, you're literally giving something in the same category as clonidine. So you're literally given an alpha-2 agonist, right? So it is a vasodilator. Don't forget that. Just because it's not called clonidine doesn't mean Precedex isn't a vasodilator. So in the world of OB, really blood pressure is a huge issue, especially if it gets too low too fast. When a baby's connected to the placenta, that the blood pressure is perfusing. So I made a few notes here. I try to watch Precedex with someone with preeclampsia, especially if it's just diagnosed the last like week or so, 2 weeks or something like that, and they've had elevated blood pressures, and the baby's been able to see the elevated blood pressures for, you know, a good week, 4 or 5 days, something like that. They get used to those blood pressures. So you drop a blood pressure significantly from what the baby's gotten used to, that's when you head into a C-section real quick too. So I'll give it to someone with preeclampsia, but I'm definitely a lot more shy on the dose. So, and especially if they've had preeclampsia and they've been in, say they've been in the hospital the last day, and the OB doc is trying to give labetalol and you know, hydralazine or whatever for blood pressure. You know, I'm pretty aware if that's happening, you know, that this is their blood pressure with hydralazine. If I add a sympathectomy on top of that with an epidural, and then I add a direct vasodilator on top of that, you know, that might be a bad scenario to be in. So definitely when you give Precedex epidurally or IV for labor, make sure the nurses know that you should not hesitate one bit to have ephedrine, because like I said, not only you have a sympathectomy, but you got a direct vasodilator. So most of the time I just have them grab it and pull it in the room, just because I don't want them freaking out, spazzing, going back to the med room, and then trying to dilute it down, you know, to give 5 or 10 milligrams. So, and you know, I tell them not to hesitate to give it, especially if you see any fetal distress with it. Precedex given, we usually give it through the epidural, so usually the dose of the epidural and IV is about the same, so 0.25 mics per kilo. I kind of cap that off around 30, just because, you know, on someone who's like in the 160 club, so, you know, you get the old circular people that are 160 centimeters, 160 kilograms. You know, if you start making the dose of Precedex based on that, when they get above, you know, 130, 140 kilograms, sometimes it is a little too much for them. I found that there's a little too much direct vasodilation on that. So if someone's 100 kilos, you know, if I wanted to give them a dose through the epidural, I'd give them 25 mics through there. And we'll kind of talk about what to do with that. I usually don't give that right up front. So I want the local to take effect, and I want to know that the epidural is good. So even if you don't have that good of an epidural, if you put Precedex in there, you got an adjunctive analgesic effect. So you might even mask not that good of an epidural that might show up as they progress. So I really want to see if fentanyl, the synergistic fentanyl and local together will give you some good pain relief before I slam Precedex in there, you know. So I wouldn't hesitate to put Precedex up front, but I would definitely wait to bolus it, maybe to give the rest of the 1%, evaluate, make sure your blood pressure is good, no fetal distress, and then if they're still having some significant pain, I might give that to their epidural. Now local acts like, 10-15 minutes, pretty quick. Lidocaine acts real quick. If you're looking for Precedex, just kind of what I've seen, I haven't read this because there's really not much data, but when you put it through an epidural, you're going to look at like 20 minutes or so before you want to reevaluate them for pain for that. So it's not like instant relief. So that's another thing when you're going to the OR with an epidural for a C-section. If they tell me ahead of time, say it's just failure to progress, they're like, hey, the OB docs in the office, they're coming over in 30 minutes or 20 minutes, and we're gonna turn the Pitocin off. The epidural's working well, but we're gonna do a C-section. That's a great scenario. If I go over there, blood pressure's stable, epidural's been in 8 to 12 hours, something like that, that's a perfect scenario to where I can give 0.25 mics per kilo of Precedex in before we're going like a spaz back to the OR and we're going to cut in 8 minutes, because really I don't have time to even hardly get the local in, let alone the Precedex if we're spaz going to the OR for like a real urgent C-section. So there is a lot of scenarios where we're going to a C-section, I'll give it. There's a lot of scenarios that it's just not feasible. But if you've reevaluated and they had pain and they had Precedex before, they say the adjunctive analgesic effect of it lasts, up to a day, which is kind of nice. So if you can get it in there, if they're having pain and they want you to reevaluate, or when you reevaluate after placing it, and you got a bilateral epidural, you can bolus it with a little, and then maybe throw some Precedex in behind. That's probably good for a future C-section too, to know that you already have the Precedex in there, which will help. And then the nice thing is you won't have a C-section, which is a moderate amount of blood loss on top of a direct vasodilator that just got placed, and then plus or minus sympathectomy, which is a whole nother discussion we'll talk about with spinals. So when I do say I came back and they still have a lot of pain, I have them recheck them right after my initial placement, and I give them the 1%, the 4 mils of 1%, and they still have pain, but the medicine's going bilaterally because we did the ice test, then that's probably the earliest I'm going to reach for Precedex in that scenario. So it used to be if we come back and we bolused with 0.25% or 1% an epidural that we deem that's bolusable, we would give 5 to 7 mils. Some people I've seen give 10 mils through there. You really got to cut that back if you give Precedex at the same time. So 5 mils is about the max you want to give anyone of 0.25% or 1%. This is for labor, not C-sections now, with a dose of the Precedex. Now I always try to put the Precedex in first and then put the local past it, just to make sure it gets to the epidural space first, since it has a longer mechanism of action to take. So. Same goes with we're doing a C-section. Say I can get that Precedex dose in we talked about. When the OB doctor's coming over, it's failure to progress type thing. If we can get that Precedex dose in, I'll go out to the room, put it in, and then go pull up some lidocaine. And I'm still going to use 2% lidocaine, but you really got to cut that dose back. I wouldn't give more than 10 mils. Sometimes 5 does it. You just kind of got to see. But if you can get that in 20 minutes before, 5 to 10 mils of 2%, if you have a decently working epidural already, which we checked before we even bolused it with Precedex, usually that's a good scenario to have good results in. So, but definitely don't try and give them 20 mils of 2% for the C-section with a Precedex dose. just because we were all so used to giving 20 mils of 2% with epinephrine for a C-section. Your blood pressure is gonna drop a lot. Okay. See where I'm at here. Oh yeah, so Precedex in the spinal. We're almost done with Precedex, I promise here. So Precedex in the spinal, you got an elective C-section. Usually the dose is 5 mics. I've seen 10 mics. I don't generally do it just because spinals aren't spotty, right? So a spinal either works or not unless you didn't put all the medicine in the spot in the space, which is why it's so important to swirl 2 or 3 times when you do. And if you don't get a swirl back, put the introducer back in and make sure you get a swirl. Because usually if you have someone that says, hey, this spinal isn't working, it's because all the medicine didn't get there. Or in the recent scenarios, we had like a hurricane, and then when COVID happened, there were supply issues, and they were sending us, I don't know where these spinal kits were located at, but they were in someone's back garage for however many months, non-temperature controlled, and we would get hyperbaric bupivacaine that, say 100% of the drug was in there when they put it in. It might be 60% now or something, but that's a whole nother discussion. You probably don't have to worry about past 2022, I would imagine. But I don't think you're wrong to put Precedex in a spinal. I just don't see the point in it. I like to have a narcotic in the spinal if I can. The synergistic effects. I usually use morphine. To me, fentanyl is just going to go away too quick. I want the patient to have more pain control later. And I don't want a ton of volume. I don't want to put Precedex in there, and then I'm putting fentanyl in there, and then I'm putting morphine in there. Well, then it's barely even hyperbaric. Your swirl might suck, and then you're trying to put 2 mils in. The patient's moving. You might have to readjust the needle again because you're not in the space. I don't know. It just seems kind of overkill to me. I also kind of like to save Precedex for an IV dose. Now, I'm not saying you can't give it spinal and IV, especially if 5 mics is your spinal dose, which is such a tiny dose. There's 200 mics in a 2 mil vial. To me, it just doesn't even seem worth it. But, if you gave 5 mics spinally, I've never read this. There's not really much data on it, but I'm sure you could still give an IV dose of 0.25 mics per kilo or less. So a lot of times an OB I'll round down, especially if there's a sympathectomy. I did a spinal. If somebody's 100 kilos, I might give them 20 or 15 of Precedex through the IV, especially if the C-section's taken a while. You think your spinal might be starting to wear off. Shivering is another good thing. You give them 10 or 20 mics. They said that does good for shivering. So I kind of try and save the Precedex C-section spinal. I try to save the Precedex for my IV dose, just because I think it comes more in handy, and it's a bigger dose. I feel like it's going to have more effect than 5 mics in the spinal that I really couldn't tell you if it worked or not, because the spinal's complete and they're not going to have any pain if they have a spinal, and then if you put Precedex in there, they're not going to have any pain either. So I don't know. Seems like such a tiny dose though that I don't know if I'd mess with it. I think that's about all I wanted to talk about that. But when you think about spinal, so you're going to get a big sympathectomy from a spinal. I always felt like I didn't want to have a direct vasodilator on top of a pretty moderate sympathectomy with a spinal, and then moderate blood loss that can be large blood loss. That's a bad combo for blood pressure for mom. So I just don't do the Precedex if it's a spinal. Now the epidural is going to have less of a sympathectomy, so I kind of feel better if I put epidurally placed Precedex and don't have the spinal sympathectomy. I think the other important thing I always kind of stress to people is, and we'll do that when we go over the scenarios of when you're having an urgent C-section, stat C-section, anything in that scenario that's not elective, like it's time to go. You can't be over there pulling up morphine and putting it in a TB syringe, and then let me get the Precedex and put it in a TB syringe, and let me get some fentanyl and put it in a TB syringe. So most of your C-sections, especially after hours that are urgent, or stat, you know, you just want to get some local and get it in there. You want to get the right amount of local, get it in there, and you know, if you could throw some narcotics in there, that'd be good. But you know, morphine's probably number one on my list to get in there. Fentanyl's really never on my list to get in there, but I guess I see why some people do it. I don't know, it just seems like overkill. And then Precedex is down here. So you know, if you had an elective C-section, if I had a SRNA student that pulled up 5 mics of fentanyl and put it in the spinal, I wouldn't like spaz out or anything, but I don't know, just kind of go through that. Okay, so now we'll move on from kind of talking about C-sections, Precedex, we're kind of done with that. Now we're going to move on to meds for a C-section. So remember, everyone that's in their 3rd trimester, they all have full stomach no matter how NPO they are. Everyone that's on labor epidural, at least on the units I've ever been on, their NPO are clear, so they're not NPO, even though they couldn't be NPO even if they were fully NPO, because they all have like kind of temporary gastroparesis from the hormones of pregnancy. So you can't treat anyone like they're actually NPO, especially in their 3rd trimester of pregnancy. So that kind of controls what you can do as far as sedation in a C-section. So we'll kind of talk about meds for a C-section. So that rules out you can max somebody, right? So propofol is the number one you cannot give during a C-section. I've heard of people doing it, and they say they're giving anti-nausea doses. Yeah, that's all well and fine, but if you ever have someone aspirate in front of you and that happens, it is indefensible, because you literally gave someone a drug that inhibits the upper airway response to stimulation and provides unconsciousness. Because they'll, you know, if you ever have to go to litigation or something, they're gonna put the propofol's definition up there. Well, if you go look at the definition, especially if you're a layperson, it's not gonna look very good if they aspirated right after that. So propofol is a no-no. You can't give it in this OBOR unless you're doing an RSI and going to sleep. So there's other drugs you can give out there. Most people that are nauseous during a C-section are nauseous because of hypotension. Well, guess what doesn't help that? Propofol. You got another direct vasodilator. Or the other reason they're usually nauseous is they have food in their stomach because they're not fully NPO. You know, people that come off the street and all, like, you know, they come in for stat urgent C-sections, didn't really know they got a hamburger in there or whatever. And the best thing they can do is literally throw it up. So you're not gonna, and the worst thing you can do in that scenario is give propofol, right? So they're nauseous because they're not fully NPO, and then you're gonna give them that. And by the way, during pregnancy, your MAC level's lower too, so it takes less sedation to get you unconscious and not have an upper airway reflex. So propofol, big no-no, but you'll see it out there. It's indefensible if it ever goes to litigation or something like that. Okay, it basically would be like doing a MAC in the OR on someone who's not NPO. So really, C-sections are limited to conscious sedation. Ketamine's involved in that because it doesn't inhibit the upper airway response to reflexes. It, you know, it does have properties that makes you go off into la la land for sure, but most of the time you can still talk to them. Sometimes for 5 or 10 minutes after a dose, you know, they're kind of out there and they won't really respond to you too much. But ketamine before the baby comes out is acceptable to give. If somebody's anxious, spazzing out, so you got like 17-year-old first kid, a little dramatic, they're just going ballistic, you ask them if they, you know, do you want to kind of have some chill out medicine? Really, your only option is ketamine. Precedex doesn't really sedate that well that I've ever noticed, you know. You give a dose and, you know, their pain might get better if they have pain, but, you know, Precedex it's not really a good sedator. Plus, it's direct vasodilator, so the dose you'd have to give to sedate would be, you know, 0.5 or 1 mic per kilo, which is going to plow their blood pressure down, and they have a baby connected to them. So really, ketamine's your only option beforehand. Benzos and opioids, both of them are going to cause direct ventilatory depression to the baby. Ketamine's only been shown to increase the respiratory rate a little bit, so their tidal volume usually stays the same. Their ventilatory drive stays the same. For anxiety, I usually get 0.25 milligrams per kilo, and if I have an epidural that, you know, we went in a stat scenario, I really didn't have a chance to evaluate it, But we're in the room, I'm either using the epidural or intubating her. There's no in between. If I feel like she's feeling anything or she doesn't want to be there, if she doesn't want to be there, I'll give her 0.25, but if I feel like she's feeling stuff and I'm trying not to intubate her, I'll give her 0.5 milligrams per kilo. And I do that really according to kilograms. So, if they're 150 kilograms, I do it according to that. So that's generally the drugs you can give there. Once the baby's out, you can give opioids and benzos, right? Still no propofol because she still has a full stomach for 6 weeks afterwards. You can give more ketamine, but I usually try not to. They're all young, healthy females for the most part, so if you do give ketamine beforehand, really when baby comes out, cord is cut, you should give some benzos to help minimize any of the bad dreams they might remember. So even if they don't ask for it, I usually give them Versed afterwards. So babies, cord's cut, baby's away. If they have any pain or anxiety after that, I would just dose it with benzos or opioids. And I always have a little thing in there saying I kept meaningful communication with them, because they are a full stomach, so really you're giving conscious sedation, not a MAC, right, at that point. So you can't just give them 10 of Versed and 300 of fentanyl and put an oral airway in and say, well, at least I didn't give them propofol. It doesn't really work like that. So, but always type in there, you kept meaningful communication with them. Of course, RSI drugs. So propofol is the only time you're going to give that in OB/OR. You should be RSIing, or you're at the end of an algorithm and you're putting an LMA in or something like that. End of an difficult airway algorithm. All pregnancies up there with difficult airways. So if you go look at a list of difficult airways, pregnancies there's more swelling. They're more likely to bleed because the tissue is more friable. I've never had a problem intubating a C-section. I'm sure it's there, even the really big ones. But I think people spaz out a little bit just because it's kind of unfamiliar territory. But the nice thing is their next move, which is more than what you can say for a lot of 80 or 90-year-olds where their neck can't do more than that. Usually they have good mobility. You just don't want to send someone down there that's kind of a novice and try 2 or 3 times. That'd probably be the biggest thing you want to stay away from. You'll have a bloody secretion-filled airway that you can't manage. So RSI drugs, sucks, propofol, lidocaine, rock, all of them are safe to give when the baby's still connected. So the one scenario I went into where I almost gave someone who had a family history of MH succinylcholine was a stat C-section. Luckily someone had pre-op them, and and I tell all of our staff, the students and ECRNAs I'm with, it's really important to ask them when you're doing an epidural, hey, do you have any problems with anesthesia, any family history of anesthesia problems? Even though you're not doing a case, you're just doing a procedure for them, you need to ask that, because somebody had a family history of MH, they didn't have anything on their allergy band, and when we pre-opted them earlier in the day, we added succinylcholine to their allergies, and then I got called that night for a C-section on them, and it was a stat C-section, epidural wasn't working well, and since there was a succinylcholine allergy on there, I knew not to give sucks, which, if that wouldn't have been there, and say we never even did an epidural on them, that's about the only time you're ever going to see someone who has a family history or a personal history of MH get succinylcholine. It'll be a stat C-section, mom, baby's unstable, nothing's on their allergy list. It's not like you have time to go through their chart. So that'd be about the only time, I think, realistically, you could ever even see that and it not be a complete mess up. So always important to ask an epidural if they have any problems like that. And then add succinylcholine to their allergies, because that always piques everyone's interest, even ER docs or anyone. So, okay. Of course, Precedex, I didn't add that in there, but sedation prior to the baby coming out, Precedex is another one. Like I said, I'm never impressed with the sedation for it, but an IV dose takes about 20 minutes. Well, your baby's already out for that, so. If I do give it, usually it's post-baby coming out for shivering, or if I think their blood pressure's okay, their sympathectomy is kind of resolving, I'll give it just for adjunctive analgesic going forward. So I try to squeeze it in on everyone if I can. Okay, so that's pretty good. Talked about propofol. I talked about CSEs earlier. Like I said, here it's just not that applicable to do, and almost everyone you can get comfortable with an epidural. So I didn't know that in residency because we would always, you know, do CSEs or, you know, I don't know, we just never really messed if someone had 8 or 9 centimeters, if you could actually get them comfortable with epidural, especially with Precedex, you certainly can now. So, okay, I was going to mention a little something about lateral epidurals. I really don't do lateral epidurals. I feel like it makes your life harder. You're more than welcome to, but especially if you don't have max inflate on a bed. You know, they got that big hump in the bed where they've been sitting, so they're right where the lumbar spine is. They're going to dip down like that. It's going to make your life harder. I mean, if someone says they feel like pushing, but they still want an epidural, they want me to try, you know, I'll take a deep sigh breath and say, okay, I will, but I don't, you know, I would never choose to do a lateral epidural over sitting epidural. Sitting epidural is always easier. Okay, I think we're good. Now we're going to go through like a little C-section, what you call that, like a chart type thing. So hopefully you guys can see this well. Let's throw that over here. So here's C-section, okay. I don't have good penmanship or drawing, as you guys noticed, so try not to judge me. So we got stat, and this thing isn't that stable, but I'll try not to push it down. So let's go here. We'll put urgent, and then elective, and I'm gonna put this, I'll put this in the descriptions down below to where I'd be able to print this out. Just I might have it in my crappy handwriting, or maybe I'll type it out. We'll see here. Okay, so stat. This is just some thought processes here. This is usually this is ongoing, fetal, and or maternal distress. Okay, so this is not resolving either mom. This is usually blood pressure way low. Usually this is like a placental abruption, you know. And if mom's distressed, fetal's distressed, because there's no such thing as having 80/40 blood pressure, thrown up all over the place, you're semi-unconscious, and baby doing okay, right? So sometimes there'll be ongoing fetal distress without maternal distress. So those are usually just heart tone stuff. So ongoing is the key word, right? Not resolved. Now remember, something can go from urgent back to stat and back the other way at any time. So don't be like, oh, they called me for a stat. Well, I know what a stat is. You know, the secretary that calls you, just, you know, somebody just tells them stat, they're just going to repeat stat. So, you know, don't be like, oh, dear God, it's a stat, I have to intubate them, right? So, because all stats don't stay stats by the time you get there, right? Sometimes they're back to urgent. So now we're going to say ongoing fetal distress and ongoing fetal distress. Right here, we'll make this easy. This is an RSI, right? So ongoing maternal distress, stat C-section, that's an RSI. There's no question about it. Remember, their MAC is low. They have a lower MAC, so generally, especially if they have low blood pressure, I'm going to give them like 0.5 milligrams per kilo of propofol, or you know, you can give them etomidate, or if you want to give them ketamine or something for induction. Just keep all those doses low. So here's the other side. This is where people mess up quite a bit too. Okay, so this is epidural, and this is no epidural. So this says mom is awake. Yeah, she might be flipping out, so you might need to give her a dose of, you know, 0.25 ketamine, which is fine. But this is saying ongoing fetal distress. You don't have time to do a spinal, not at all. So if they don't have an epidural, you're at RSI right there, right? If they have an epidural and it's not working well, you're close. If it's not working well, if not working at all, you're at RSI. But this kind of scenario we talked about before, if it's not working well, you can try the 0.5 milligram per kilo of ketamine. That's about the only time I'll ride a dirty epidural to the OR there. So, And then if it doesn't work, I'll just RSI him. So usually I just have Dad step out, or I wouldn't let Dad in there to begin with, maybe, if I had a suspicion that this was going to be the route that they go. Okay, the epidural is working well. So this scenario, this is, remember this is a stat C-section. We're not going to give Precedex, right? We don't have time for that. So we talked about the times when you have Precedex. Plus, if you're talking about ongoing fetal distress, the last thing you want to do is give them a direct vasodilator, right? Because sometimes, you know, the fetal distress is for their cord or whatever, something situated, something that's OB that's their specialty, not ours. But the last thing we want to do is lower the blood pressure on top of that, right? Now, once the baby's out, yeah, that's fine. You know, sympathectomy is looking okay until baby's out. So this is when we're going to try and do the 20 mils of 2% Lido with Epi, right? So we're going to try that. And then I would not hesitate to give some anxiety ketamine here, because they're going to be flipping out, right? Everyone's going to be spazzing, going to the OR, there's going to be all these alarms going off. I wouldn't hesitate to give that for that, especially if I didn't have the chance on the stat. I'm not going to be able to go in there and say, hey, let me put ice on your knee and your chest, you know, while your kid's heart rate's 40. So I wouldn't hesitate to give that, just in case it might be not as good epidural as what you would think it was. But definitely slam 10 when you get in the room, get a blood pressure 4 or 5 minutes later. They're going to cut in 7 minutes, probably 8 minutes. So try and get another 5 in. If you can get 20 in, you know, more power to you. Make sure I'm not going over time here. Okay, good. So I think we got through all that. Yep. Okay, so that's urgent, okay? So sometimes they'll call you for a stat, but baby all of a sudden looks fine. So they had some ongoing fetal distress that resolved, though. I guess so it's not really ongoing, but they had fetal distress. They called a C-section, thought it was going to be stat. He came over there in 8 minutes, and they're like, nah, baby's heart rate's 160, we're going to C-section anyways, okay? So that's still an urgent C-section. Start out as stat when they called you, but then it's going to turn into urgent, right? So this is almost always fetal distress that has resolved. Okay, or failure to progress, right? So that's most. I'm sure there's some other stuff. I'm not an OB doctor, so you know, if you want to go over those indications, you're more than welcome to. But it really doesn't change what we're going to do, right? So we either have an epidural, right? Or we have no epidural. I'll try not to stand in front of this. So it's working well. And we use it, right? Yeah, that's an easy scenario. And we already kind of talked about what to give there. You know, say if it's failure to progress, sometimes you'll be able to get the Precedex in. If it's fetal distress, I mean, usually, you know, by the time I get here, we take home call. They're in the operating room, so I don't really pull the Precedex out. You know, I'm going straight for the 2% because they're going to cut. You know, they're going to have baby out in 10, 11 minutes, somewhere around there. So, kind of depends on your scenario. Let's say the epidural is not working well. So in this scenario, say they're not in the OR, they're about to go back to the OR, you get some ice, it's just failure to progress. OB doctor's on the way in, you make it there a little bit before them, and you know, you do the ice and it's not working well. So, you know, they're like, oh man, that feels really cold, feels almost as cold as it does up here. Okay, that's going back to the old dirty epidural there, right? So we're gonna remove, and we're going to go to a lower spinal dose, right? Okay, so usually about 1 mil, somewhere around there. Now you got no epidural. Oops, I didn't put no there. This means we need to do a quick spinal, right? So this is the scenario where I said you probably wouldn't be able to put Precedex in. So probably no Precedex, right? Last thing you want to do is be pulling 5 different things up. Sometimes I'll try and get some morphine in there if they're not in the room yet or whatnot, but if at any time this distress comes back, you just changed it back to here. So they're going to be monitoring the kid the whole time. So if that's the scenario, you might sit someone up, oh, baby doesn't look good, boom, we're going back down to no epidural RSI because of ongoing fetal distress, okay? So you can't be a spaz about it, you just kind of gotta take it as it comes and ask the OB doctor. They know what fetal distress is, right? You're not an expert in fetal distress, don't act like you're an expert in fetal distress. That's not any of our specialties. And even I did 2 months rotation in OB and OB labor unit, and I still know I'm not an expert in that whatsoever. So talk to your OB doc, your midwife, say, hey, do I have time, 3-4 minutes, let me try and throw this spinal link so we don't have an epidural. Because really, if you can stay away from manipulating a pregnant person's airway, you're doing the best thing you can for the patient, right? The reserve is lower too, that we talked about. So now this one, I don't hesitate to grab a 22 gauge needle or whatever your larger gauge needle is that is not your 25 gauge needle that's in the kit. So, and we go fast. And what are you gonna do? Perforate the meninges? Good. That's what you're trying to do. So, I mean, you'll see me. I'm going. I'm just plowing in there. And as long as you're experienced and you know what the feel is to go through like the ligamentum flavum and into the meninges, everyone that's done OB for a while or anesthesia OB very often, they know that feeling pretty well, especially with the 22 gauge. You can feel that pretty easy. And this, most experienced hands, right? So, this is not a time for a student to be doing a spinal, okay? And if it is, you give them about 30 seconds, and then you're taking over. So, and you have gloves on, you're not waiting to put gloves on, you're saying, I'm gonna give you about 30 seconds, here's a 22 gauge, 3.5 inch needle, good luck, right? All right, so elective, these are the easy ones. So this can be a spinal or an epidural, right? Epidural is usually, the only time you would do that, get in this scenario, would be if you tried a spinal, you couldn't get it. And I think in 12 years I've been doing this, it happened once, and then I got an epidural, and I just used that instead. So that shouldn't be too common. Usually you should be able to get a spinal. But if you couldn't get either of these and had to put them to sleep, that's almost a never scenario. I've seen people do that where they're just like, nope, can't get it, I'm just going to put them to sleep. Well, yeah, that's fine until it's not fine, because you got a baby connected to that placenta, and if you mess with a difficult airway, make it bloody, swollen, and then you got hypoxia, you're sending the hypoxia to the baby, you could have a big storm on your hands before the baby comes out. So not only are you hurting mother, but you're hurting the baby. So that's almost a never event. I've never done that in 12 years. I've never said, oh, we're just going to tube her since I can't get this epidural or this spinal. So, and so outside of that, the contraindications, this is where you look through it. If they have back surgery, and they got metal, if you can go above it, that's good. That'd be one of the few times. I try not to mess with other people's metal. You start shoving a needle all over the metal of someone else's implants back there, and then they get infected afterwards because you rub metal on metal and there's nidus and inflammation. Now you just had them to get, you could put them in a scenario where they had to get their hardware removed, and we all know what patients' outcomes are with back surgery to begin with, let alone revision. Back surgery like that. So if someone had metal that was like here, down to here, there was fusion, I would just put them to sleep. But you'd be validated doing that. So, of course, coagulopathy, you need to be under 1.2 or 1.4 on your INR. One of the weird ones is if your OB doc says, hey, you need to be aware of this scenario. We got a CRETA, whatever, and we're going to think we're going to lose 1,300 in blood. Well, in that case, the worst thing you can do is probably spinal. The second worst thing you can do is probably an epidural, because you're going to have sympathectomy, large blood loss, not moderate blood loss, large blood loss. And then the third worst thing you can do is give them Precedex, because then you're putting a vasodilator on it. So those, you might do a general anesthetic for. Someone with severe anemia, they have hemoglobin of 6, 6.5, 7, somewhere around 8. You probably want to get their blood up before you go do this C-section. If you're in this scenario and you have to do a spinal, that kind of sucks. You better get the blood up there real quick or decide to intubate them before that, because If you can't get blood in them fast enough, you're going to be pressing them so hard, you might make the babies, mom's hypotension be so significant it really hurts babies. So make sure I got a little time left. Okay, good, perfect. Like I said, urgents can go to stats at any time. I kind of talked about the 2 doses for ketamine. In general, I use about 1.4 hyperbaric for most women that are having a kid that are from 5 foot to 5'8", 5'10". You know, if you have someone closer to 6 foot or below 5 foot, I might up or down the dose, you know, 0.1, 0.2, something like that. So that's usually about, you know, once you start doing it a while, you kind of get a good feel for it. I feel like all of our feelings for that are off just because we've had so many spinal kids come that had in a not fully 100% effective medicine from degradation from temperature storage or whatever. I don't know what the hell it was, but I think it's kind of messed a lot of us up, especially since 2019 or whenever that hurricane came. And then with coronavirus and everyone's having these problems with delivering stuff. So, okay, I think that's about it. So if you guys have any questions, you're more than welcome to comment. I'll try to respond or something like that. Hopefully it's a good overview. You can't hit every scenario there is, but this pretty much hits most scenarios. You know, there's always going to be something you have to be flexible for, but I think the main point is don't be dialed into one thing. You know, hey, this epidural is not working, but I'm still going to just go back to the OR. That's the worst thing you can do. That's when you end up on YouTube for a bad reason and dad's videotaping you, mom's doing a sit-up, going ballistic, even though you're trying to give her ketamine and all this. And that's when people start getting propofol and stuff like that. And if you had someone like me reviewing that record and a complication happened, you wouldn't even go to trial. You'd get deposed and it'd be over with. So, you know, we want to take care of the OB patients. We want to make sure everything's safe for them and the baby. That's the most important. So try not to get your pride or feelings or anything hurt in there. And, you know, if somebody calls and, you told me it was stats, so I'm intubating them no matter what. Well, you might be over in this scenario right here, and you just intubated somebody for no reason. So, okay, sounds good. So I hope that helped everybody. Like I said, if you guys got any questions, I'll try to comment as I can. Thank you.